that your system doesn't work. Okay? Now, either partially or totally. Now, the other one is obviously if the system works, and of course it decides that it works against you. Okay? And that's autoimmunity. We'll start with that. So basically, I show this picture because the efficacy of a weapon is really dependent on who uses it. Okay, so just because you have a powerful system that does something, sometimes these powerful systems are not that wise and act against you instead of a perceived enemy. Okay, so basically autoimmunity, okay, resolves to a failure of mechanism that controls or that maintains self-tolerance. Okay? In other words, your body is now reacting against your own tissue, either because of some aberration or because the tissue now looks foreign. Now, once again, there's a lot of crossover mechanistically between hypersensitivity and autoimmunity. So there's a whole bunch of multiple factors that are suspected to play a role in autoimmunity, okay? Although many of them are not very clear as to why this happens. Now, why is it that you react yourself? How come you have an immune response to self-antigen? And once again, there's many different theories. You know, when I talked about immunological tolerance, the positive and negative selection, okay, that is central tolerance versus peripheral tolerance, which is tolerizing cells like B cells. I told you that this system is not perfect. Okay? So therefore, you have other mechanisms in addition to central tolerance. Again, central tolerance being positive selection and negative selection, that maintain some of the potentially self-reacting cells in check. So if you have an imperfection on central tolerance, and if you also have some sort of aberration in a mechanism that keeps self-reactive cells in check, then you have loss of regulation of these cells and an autoimmune response. Now, the bottom line, though, that there's still a lot of unknowns about autoimmunity, about why it is that all of a sudden your immune system reacts against yourself. Now, what happens in autoimmunity is basically the result of standard immunological reactions. In other words, the mechanism that caused the clinical results of an autoimmune reaction are the same ones that your immune system uses to get rid of a perceived enemy. Okay, they're the same thing. So, for example, immune complex-mediated injury, when we talk about a rheumatoid arthritis or lupus, or antibodies against a particular tissue. So here's an example of the deposition of immune complexes onto some sort of surface, for example, the inside of a blood vessel, and now you have the immune system in trying to get rid of these particular immune complexes. Once again, I repeated ad nauseum, that the immune system has a shotgun or a flamethrower approach, okay? And so what happens is you have recruitment of neutrophils and other cells, activation of complement, and all of this in trying to get rid of these complexes also damages the tissue on which these complexes are deposited. Or if you directly have antibodies to the tissue itself, not so much immune complexes, but actually antibodies that are made to what now, for some reason or another, looks foreign. What antibodies do is they activate complement. They do other things, okay? They recruit phagocytic cells. And so therefore, if you have antibodies to some sort of self-tissue, your immune system reacts to any other antigen like that, and of course causes tissue injury. Now, autoimmune reactions or diseases can be classified either by an organ-specific or systemic diseases. And of course, the organ-specific, as the name implies, are autoimmune diseases that target a particular organ, a particular system, okay? So the response, the immune response, is where an antigen is associated with a particular tissue. And there's two general types of autoimmune diseases, mechanistically, that are associated with organ-based autoimmune diseases. Diseases that are caused by cellular damage, where the immune system physically damages the tissue on which these antigens are deposited, or disease caused by either stimulating or blocking autoantibodies. So we'll go through some examples of all of these. Now, what are organ-specific diseases? Some of the hemolytic anemias. Remember that I told you there was the example of the workers in the textile industry where you have formaldehyde many years ago that altered the shape of surface proteins on red blood cells, and now you had an autoimmune response to the red blood cells. And of course, you have activation of complement, and the red blood cells will be lysing, and you have hemolytic anemias. Or sometimes there's certain drugs that can somehow what is called heptenize or alter the shape of a particular tissue, for example, penicillin, okay? And that in turn can make the tissue on which this heptenization occurs, such as red blood cells, look different, look foreign, and the body reacts to it. Now, here's an example where the antigen happens to be on your thyroid, and now what happens? You happen to have an immune response against your thyroid, okay? You have tissue destruction, and you have hypofunction of thyroid. And what happens? What happens is that you have a lot of different problems. It causes goiter, blocks iodine uptake. It decreases production of thyroid hormones because obviously if the tissue is damaged, if the organ is damaged, you cannot make the stuff that you usually make. Okay, and here is a classical example. Here is a cartoon of goiter with an enlarged, inflamed, hyperfunctioning thyroid. And here is a clinical picture of the same thing, classical goiter found in Hashimoto's thyroiditis. Another example of tissue destruction antibody autoimmune diseases is Goodpasture syndrome, where you have antigens that are deposited onto the kidneys, okay, and also in the lungs. And what happens? When you happen to have antibodies that are deposited on the particular tissue, you have activation of complement, you have recruitment of inflammatory cells, and now you have the destruction of that particular tissue. And here is a picture of, for example, of a kidney glomeruli where you have, excuse me, where you have the deposition of antibody that is characterized by the green fluorescence. Okay, a fluorescent stain that is hooked to an antibody and in turn detects antibodies on the tissue. Classical example of autoimmune diseases caused by autoantibodies is type 1 diabetes. Okay, insulin-dependent diabetes mellitus, where you have an immune response to various different pancreatic beta cells, which in turn are the ones that produce insulin. And so what you have is the destruction of the cell, you have decreased production of insulin, and in turn you have what? You have altered carbohydrate metabolism, okay? Which in turn causes all kinds of different metabolic and physiological problems. I'm not going to go to the biochemistry of diabetes because it's beyond the purpose of this class, but you know, obviously ketoacidosis, increased urine production, et cetera, et cetera, et cetera. Multiple sclerosis is also another example where you have, there's some circumstantial autoimmunity evidence. You have a situation that you have a response to basically the insulating sheet of the nerves. Okay, so you have of the myelin on nerves, and of course, if you have destruction of that, you have decreased neurological function. Now, the other problem that can happen in an organ-based autoimmune response that may not necessarily involve typical destruction of tissue is alteration of function. So antibodies made to a particular entity can not only destroy, but even if they don't, they can cause functional aberration. And I'll give you two examples. The first one is Graves' disease. Okay? In Graves' disease, you have antibodies that are generated against a thyroid-stimulating hormone receptor. For some reason now this dude becomes foreign looking. And what happens? What happens in this case is not so much the destruction that is caused by the antibodies, but the antibodies stimulate the receptor. Okay? They act as agonists. Okay? They mimic the hormone. Now what's the problem? The problem is that in a regular hormone receptor system, you have feedback mechanisms. Okay? So here you have the thyroid. You have the pituitary gland secreting thyroid-stimulating hormone. Okay, the thyroid then gets stimulated and produces thyroid hormones. Now, these thyroid hormones, once they reach a certain level, they tell the pituitary to shut down. I have enough of these guys, so don't make any more TSH. And this is a classical feedback mechanism of many different endocrine systems. Once again, we have the pituitary secreting TSH, stimulates the thyroid makes thyroid hormones. These hormones, once they reach a certain level, feed back to the pituitary to stop making TSH. And of course, the whole system then slows down or shuts down. The problem in Graves' disease is that you have antibodies that mimic the hormone, mimic TSH by stimulating the receptors. So the thyroid now thinks that is receiving signal from the pituitary and produces hormones. The problem is it does that continuously because there's no feedback mechanism, okay? In other words, the hormones are telling the pituitary, shut down, we got enough of it. And the pituitary is saying, I ain't doing nothing, man, it's not me, okay? So in other words, this happens to result in overproduction of thyroid hormones, and of course you have all kinds of different clinical symptoms. Some actually are very characteristic. For instance, exophthalmia, which is caused by swelling in the back of the eye, and all kinds of other symptoms that are associated with Graves' disease. So this is an example where you have stimulating autoantibody that cause a functional issue. The other side of the coin is antibodies that actually block a function, and that is shown in myasthenia gravis. What happens in myasthenia gravis is that you have antibodies to the acetylcholine receptor. Okay? So what happens is that these antibodies block the receptor, and the receptor cannot get signals from acetylcholine. And this is the picture of it. Okay? So you have a nerve communicating with a muscle by a classical release of a neurotransmitter, acetylcholine, which binds to the acetylcholine receptor. The muscles get the signal and does what it's supposed to do upon signaling from the nerve. Now, in myasthenia gravis, what happens is that you have antibodies that are blocking these receptors. Okay, they're interfering with the receptor receiving the ligand, which is the neurotransmitter. So the nerve may keep all the firing at once, but the muscle ain't responding, because it doesn't get the signal from the acetylcholine. And what happens? You happen to have the typical muscle weakness and other clinical symptoms of myasthenia gravis. Okay? So this is an example of blocking antibodies. And of course, there's a whole bunch of other diseases, okay, that I could talk about each for an hour. Ulcerative colitis, Crohn's disease, Sjogren's syndrome. Sjogren's syndrome affects the exocrine tissue, affects salivary glands, affects lacrimal glands, okay? And it's really a miserable condition. If you think, oh, this is just saliva, it's no big deal, okay? I mean, you get all kinds of oral infection, caries, effect of the tongue. You can't eat well, you can't chew. You have all kinds of different things that are usually inhibited by saliva. Okay, and it's not a pretty picture. Okay. Now, these are all autoimmune diseases that target specific organs, meaning that the immune response affects a tissue that is unique to an organ, either by anatomical location or by function. However, you can also have systemic autoimmune diseases, which means that the antigen that are recognized as foreign are pretty much everywhere in the body. Okay, so the immune response really is directed to a broad range of target antigens. Okay, now some of these diseases are hard to diagnose. So All these autoimmune diseases, by the way, seem to be more prevalent in women. Okay? Now, guys, don't smirk, because when we talk about immunodeficiency, there's a lot of X-linked immunodeficiencies. Okay? So they have a lot of bigger overlap because the symptomology is complex. What is the absolute quintessential example of a systemic autoimmune disease is systemic lupus erythematosus, or LSC, or just simply lupus. Lupus comes from the Latin word for wolf, because some of the characteristic of facial features, I'll show you a couple of them in a minute, okay, remind the people, I guess, of the face of a wolf. So it was called lupus. It's like in many other autoimmune diseases, it's higher in women. And you have all kinds of different symptomology that is very difficult to diagnose. Fever, weakness, skin rashes, kidney dysfunction. You know, a patient comes to you and says, I feel weak, I have some pain, I got fever. I mean, that could be, you name it, just about anything, okay? And basically what happens, you have an immune response to a whole bunch of different antigens, to DNA, to some of the proteins that are associated with DNA, to nuclear RNA, to red blood cells. And this is a classical, okay, example of such an autoimmune disease. You have all kinds of different immune complexes that are deposited on the kidneys, sometimes in the lungs. Okay, so you also have kidney damage. You have an inflammatory skin disease called a T-cell mediated disease called butterfly rash. And here is an example of the butterfly rash that is classical characteristic of patients with lupus. Okay, here's another one where you have the classical, the reason obviously because it's shaped like a butterfly. Okay. Now, a second example of a systemic autoimmune disease is rheumatoid arthritis. Okay, well, I talked about rheumatoid arthritis when I talk about hypersensitivity once again, because most of hypersensitivity reactions are autoimmune in nature. So you have chronic inflammation of the joints, cardiovascular system, especially the synovial joints. And then what happens is that you have antibodies that are attached to a particular antigen. And this in turn deposited in various different areas, including the joints. These antibodies recruit neutrophils and other immune cells, as well as complement activation, which in turn damages the tissue on which you're deposited. Okay, so here, once again, is a classical clinical picture of rheumatoid arthritis, where you can see you have extensive inflammation of the joints, you have deformation of the joints. Okay, this is a fairly advanced case. And of course, if you look at x-rays, you can see that there's intense deformation of joints. Once again, caused by immune response that causes an inflammatory reaction just about anywhere, and also destroys the cartilage, which in turn acts as a cushion between bones, and you have in turn a miserable condition. Now, what causes autoimmune diseases? Well, there's no really an exact known cause of them, other than there are factors that are associated with it, okay? Probably more so peripheral tolerance failure than central tolerance, okay? Where cells that have escaped central tolerance are not kept in check. But there's a whole bunch of other factors that are involved in the development of these diseases. Many genetic factors. Infection plays a major role in many of them. Gender, once again, they're more prevalent in women than men. Anything from environmental factors, for instance, smoking. Smoking increases the severity of many diseases, includes some autoimmune diseases, for example, Goodpasture syndrome. Now, there are situations in which, and I didn't have the time to do this to explain this because I didn't have the time to do it, sometimes physical trauma can affect an anatomical site that are called immunologically privileged site. Now, these sites in the body are sites that are not in direct contact constantly with the lymph system, and therefore there are sequestered from the immune system. The immune system kind of really doesn't see them. So what happens is, if you have a physical trauma, and some of the examples are certain areas of testes, certain areas of the eyes, Okay? If you have a physical trauma that releases some of the contents of these privileged sites into the circulation, then the immune system sees these as foreign because it's never seen them before and reacts to them. Okay? And this is sympathetic ophthalmia. It's a classical example of an autoimmune disease that is caused by physical trauma. Now, sometimes infection can cause what is called molecular mimicry. Remember that I told you that in nature, many things are concerned and made of a limited number of patterns, okay? So you could have a situation in which you have cross-reactive antigens, antigens on a bacterium, for example, that somehow looks kind of like your own tissue, and because the body makes an antibody response to that antigen, those antibodies also cross-react with your own tissue. And a classical example is streptococcal endocarditis, where you have streptococcal antigens, antigen from streptococci, that because Mother Nature decided to make it that way, kind of look molecularly like some of the stuff that your heart muscle is made of, okay? And so you have cross-reacting antigen, and this is caused by molecular mimicry. Gender. Gender is a major influence in autoimmune responses, okay? It's really not clear why. There may be some hormonal factor for obvious reasons, okay? But the great majority of autoimmune diseases occur in women. And some studies have shown that there is a hormonal influences, okay? For example, in studies, castrated males become more susceptible to autoimmunity, and this is done in mice, okay? So we have a study next week. If any of you guys want to do a human study and participate in this, there's a sign-up sheet here, okay? Oh, come on, we'll give you orange juice and then you'll be sure. Okay, so on the other hand, since it's a bitch to get male volunteer for this, okay, androgen-treated females reduces incidence of autoimmune disease, meaning that there is a hormonal influence to this. Okay? Now, what do you do? Unfortunately, there's not really cures per se of this. Most of the treatment are carried out in reducing the immune response, in reducing the damage or the symptomology that the immune system is causing in these diseases, okay? So in severe cases, generalized immunosuppressants, such as corticosteroids, cyclophosphamide, a whole bunch of other stuff, okay? And then targeted therapies, okay? For example, cyclosporin A. Cyclosporin A kills a lot of activated T cells, and because you need activated T cells to amplify a response, okay, you kind of turn down the autoimmune response per se. Now, this is a double-edged sword because, of course, if you don't have a lot of activated T cells, you're also more susceptible to infection. Okay? So it's not an optimal situation. All right. So the other side of the coin is the immune system doesn't work, either partially or totally, and that's immunodeficiency. Now, I would say for the past, maybe 30, 35 years, the quintessential example of immunodeficiency has been HIV infection and AIDS, okay, because it's been such a big thing, okay? But you have to remember that immunodeficiencies have been around for a long time, okay, and they can be very, very bad. This is a child with defective cell-mediated immunity, and of course he's covered with cutaneous candidiasis. Here is a classical example of oral candidiasis of thrush in an AIDS patient, okay? An organism that is opportunistic, meaning that that usually is kept in check by our immune system, but once your immune system decreases in its effectiveness, then it takes over. So immunodeficiency, besides thinking of AIDS, and I'll cover AIDS, is really divided into primary and secondary. Now, primary immunodeficiency simply means that you have an inherited defect, a congenital defect, in some aspect of the immune system or the whole thing, okay? Imagine you have a car. There's a lot of things that can go wrong with a car, and each of the things that can go wrong can affect the function of the car. This is the same thing with any complex system, okay? So these are examples of primary or congenital autoimmune immunodeficiencies. Defective antibody response. If you don't make antibodies, of course, you have problems. A defective cell-mediated immunity. I just showed you a picture of what can happen in a severe case. Complement component defects, where some of your complement components, either one or two or more, don't work quite right. Defectant phagocyte functions, if your phagocytes cannot gobble up the microorganism, or if they can gobble up and not kill them, once again you have problems. And leukocyte adhesion deficiency, where you actually have chemotaxis that is impaired. So we'll cover some of these. So usually primary immunodeficiency refers to genetic defects that can affect a lot of different branches of the immune system. Okay? Now, you could have a defect in a single gene, which affects a particular molecule, or you can have a defect in multiple genes, which in turn, increases the complexity of the disease. Sometimes you have organ development that are affected. For example, in the Georgia syndrome, okay, you have no thymus, and this in turn is where T cells get trained, basically, and so you have all kinds of other physiological problems. Now, here is just an example. No, I don't want you to remember this pathway. Just get the message that anything can throw a monkey wrench in any of these mechanisms can affect and result in the primary immunodeficiency. For example, if you are not making a particular antibody, then you have a common variable hypogammaglobulinemia, meaning you're not making antibodies, okay? Or you could have a specific antibodies that is not made. For instance, you cannot isotype switch from IgM to IgA. Or you could have developmental problems, okay? Here's B cell maturation, here's T cell maturation, okay? No, I'm not going to ask you to remember these steps. Just remember that anything that can happen in this pathway of going from a stem cell to a B cell, or going from a stem cell to a mature T cell, anything that can go wrong in any of the components that are associated in this development can result in some sort of primary immunodeficiency. Okay, here are lymphocyte maturation, okay? For example, if you have a defect in T cell receptor signaling, obviously T cells then cannot get the message, okay? Or you cannot have a T cell respond to another cell by having a ligand that is necessary for that interaction. Again, all of these can happen just about anywhere in the development of an immune cell. What about defect in antibody response? Once again, if you don't have antibodies, either all of them or some particular isotype, once again, you have a car that has something that's wrong with it and it doesn't perform a particular function. Okay? And these are usually due either to a defect in B cell function, because B cells are the ones that make antibodies, and or a T cell dysfunction could also cause this, because, as I told you, B cells need to hear from T cells in order to continue on in their development. Okay? So either of these functions that are changed can affect antibody production. Or if you have cell-mediated immunity, okay, I showed you the picture of cell-mediated immunity in the effector mechanism. Of course, if you have that, you have a failure T cell function, and you have, once again, more frequent opportunistic infections. Okay, also complement. Any of the complement components that is defective, because they have a function in an immune response, either by lysing a particular microorganism, or by opsonizing, or by recruiting on its cells. Once again, any of those components could be defective. That defect, in turn, results in a particular dysfunction of the immune system. Sometimes, and I showed you this before, okay, sometimes even turning down, the molecules that turn down complement can also cause clinical problems, okay? For example, deficiency in a terminal component or the alternative pathway, And of course, I showed you this before. This is hereditary angioedema, where you have a deficiency in what turns the complement cascade off. Okay, so any aberration can cause problems. What about phagocyte functions? Phagocytes obviously are designed to phagocytose offending microorganism and hopefully get rid of them. Well, sometimes what happens is that they can phagocytose the microorganism, but they cannot generate the chemicals that digest the microorganism out, those highly reactive nitrogen and oxygen intermediate species, some of the enzymes, okay? So for instance, there is a condition where you have chronic granulomatous disease, where you have a defect in the biochemical pathway, okay? You can't work NADPH oxidase, which in turn is used to generate those chemicals that digest the bug out. And so what happens, you have a phagocytic cells that is trying to digest this, cannot do this, attracts more cell to the side, there's more inflammation, and you have the formation of various things like granulomas, okay, and abscesses. Okay, another one that is really very severe case is leukocyte adherence deficiency. Once again, leukocytes and other cells move from here to there by sticking to a surface. Okay, in other words, expressing molecules on the surface that binds to molecules on the first surface on which they walk. And I already used this analogy. Imagine that you are a spaceship in free gravity, and the way you walk is by having Velcro shoes, Velcro soles, and a Velcro floor, and you stick, okay, so that you don't float away. Well, cells have a whole bunch of these Velcro molecules that modulate cell movement, which cell goes where, when, how fast, when it comes back. So there's a whole system of these Velcro-like molecules that are used by both cells as well as on the floors on which they walk that modulate cell movement. Now, in leukocyte adherence deficiency, what you have is a subunit of one of the major sticky molecule, Velcro molecules, called the integrins, okay? And the integrins are shared by whole kinds of different cells, okay? Lymphocyte, monocyte, macrophages, granulocytes. All these, did you see this CD18 subunit right here? They're shared by all these integrins, and what happens is that because this is missing, there's defective expression of these Velcro molecules on the surface of the cell. The cell now cannot simply stick to the floor to walk. Okay, once again, it's like having bald tires on glare ice. The cell can detect the presence of an offending organism, but can't get there. And this results in pretty devastating infections. Okay, so here is an example of another primary or congenital immunodeficiency. Now, fortunately, most immunodeficiencies are recessive. That means that the genetic aberration, okay, has to be inherited as 2 copies in order to be expressed. And as a matter of fact, many recessive diseases are found in highly inbred populations. Okay, populations that are inbred, for example, cousin-to-cousin marriages, okay, in the Amish, for example. Okay, because, once again, these are usually recessive. Now, how do you know that there is a particular deficiency? Well, the most common logical thing is a person is developing infection where you wouldn't expect a person to do it. Why is this person developing infection that he or she would normally fight off? Okay? And depending on the type of infection, you can kind of narrow down where the defect is, although it's now is not that clear as low as is. Now, many of them are X-linked. That is, they're associated with the X chromosome. And because males only have 1 X chromosomes, okay, they're more likely to develop the one that is associated with it, okay, rather than somebody who has 2 of them and therefore will have the dominant one take over. And there's a whole bunch of X-linked immunodeficiency disease. The most severe one is called severe combined immunodeficiency. And this is a devastating condition where you have really complete immunosuppression. Now, there are many types of severe combined immunodeficiency. The most common one is what is called a common gamma chain, where you have receptors for cytokines. Cytokines are chemical mediators that are used by cells to communicate, and this common gamma chain is shared by a whole host of different receptors for cytokines. So if you don't have this particular component, the receptor doesn't work. And because it's shared among many different cytokine receptors, cells cannot respond to a whole bunch of different cytokines. And because cytokines are so essential as a communication means between cells, you have a completely dysfunctional immune system. Okay? The historical thing about this disease was a boy in the 70s called the Bubble Boy. His name was David Vetter, and he was completely immunodeficient, okay, had completely SCID, and had to really basically be housed in a bubble, in a sterile bubble. And eventually they made, this was also shown in a documentary, PBS documentary in the 70s, and it was even, believe it or not, a movie starring John Travolta depicting the life of this boy, okay? So this boy was completely immunodeficient. He had the common gamma defect SCID and had almost like an astronaut suit tied to a filter, okay, because he could not be exposed to anything, because anything would simply infect him, okay? And in fact, I think he died when he was about 12 or so. They tried to do a bone marrow transplant with one of the healthy sisters to try to reconstitute his immune system. But the problem with that, if I remember well, he developed Burkitt's lymphoma because the sister happened to have had a dormant Epstein-Barr virus in the bone marrow. Don't quote me exactly, I'm trying to remember the case. The bottom line is, this was a classical example of complete immunodeficiency that is genetic. Oh, and here's another picture of the apparatus that he used so that he could at least go outside in his yard and at least, you know, walk. But he usually was kept in a big, big plastic bubble. And here are other X-linked diseases, okay? Once again, these are all examples, okay? X-linked gamma globulinemia, when you have a defect of making antibodies, period. Or you have a hyper-IgM syndrome, where you're making antibodies, but it stays on the IgM side. It cannot isotype switch to other isotypes. These are just other examples of X-linked diseases, okay? And here are some more. Now, what do you do? Well, you basically try to treat the defect. So you try to replace missing proteins, or missing cell type, or missing defective gene using gene therapy. Okay, that's basically the basic approach. Okay, so for example, if you have lack of antibodies, you can have pooled gamma globulin that is administered to you. Or if you have a missing protein, such as an adenosine deaminase deficiency, okay, you can try to administer that protein to the patient. Okay, or if you have missing cells, you can try to either stimulate the bone marrow to produce a particular cell, or you have basically bone marrow transplant to try to reconstitute the immune system of a particular individual. And missing genes, the idea is to actually replace the missing gene, okay, via gene therapy. There has been several attempts. I really don't know what the current status of the gene therapy in primary immunodeficiency is, but in 2000 there was the first successful gene therapy for the gamma deficiency of SCID. Some patients were successfully treated. The problem is that when you're dealing with certain things in your genome, you have to manipulate the genome, lose very different things, retroviral gene therapy. So sometimes you screw up with the genome. You have a problem of 2 people that develop leukemia because of the manipulation. So it's not perfect. Unfortunately, there's no excellent animal model to study these immune diseases, okay? People have used a nude or a thymic mice as a model, but it's not a perfect model, Okay, it's a model that lacks the thymus, almost no T cell, so it's not really the ideal thing to study specific aberrations. Okay, I just want to show you a picture of a nude mouse. We have to be, you know, obviously. Okay, but of course now you have gene knockouts when you have inbred species to which you can inbreed a particular gene knockout and see what it does. Okay, I'm not going to spend too much time on this, but just to give you an idea. All right, so now the biggie now, when you think about immunodeficiency, because it's been on the news for the past 30-some years, it's been a huge thing, is of course HIV and AIDS. Now, I don't have to tell you, I have no idea how old this slide is. It doesn't really matter if the numbers are correct, okay? But the bottom line is to give you an idea that this is a huge, you know, it's a huge problem throughout the world, okay? Now, of course, there's certain areas that are much more affected than others. I mean, obviously, sub-Saharan Africa is the big place where HIV and AIDS is more prevalent, but certainly in North America, certainly in Latin America, certainly in Europe. So it's been a huge issue for the last 30 years. And it is caused by a retrovirus that basically kind of nobody's ever even heard of when they first studied this virus, that basically targets a whole bunch of different cells. Now, you must have had virology in this particular course. You know that I have virus that has to infect the cells, has to enter the cells, and basically uses the cell machinery to make its own proteins, okay? And HIV does the same thing, okay? Now, the problem is that in many cases, the lymphoid tissue is also acts as a reservoir for HIV, okay? So while HIV affects many cells and it kills some cells actually keep it as a reservoir. And that is one of the things that is problematic with HIV infection. So, you know, I'm not going to talk about the virology and the pathogenesis, but the cells that are affected are cells that have two particular components on the surface, the CD4 and then a co-receptor, a chemokine co-receptor, okay? So the HIV affects many different cells. Unfortunately, what are cells that have a lot of CD4? Helper T cells, okay? And helper T cells are obviously essential for an efficient immune response. Those are once again, the officers of the immune army. Those are the cells that kind of decide what to do, when to do it, for how long, how strongly, okay? So what happens is that once you affect those cells, and once these cells decline in numbers, now your immune system is affected, okay? So here is an example of what happens to you, okay, or to an individual that is HIV infected. You have an infection, and then the T cells, CD4 T cells numbers come down. Viremia goes up, and now you have what is called a seroconversion, which means that now your immune system makes antibodies against the virus, successfully so to a certain extent, okay? And so now the bone marrow tries to replenish these T cells. And now from here on, there is a constant fight between the bone marrow trying to replace the CD4 positive T cells and the virus killing them off, okay? Now, unfortunately, what happens? What happens is that there is an asymptomatic phase in which you really don't feel anything. And during that phase, some of the virus hides away in your genome and remains dormant there. Okay? Until it gets reactivated, and now what happens? This could mean years later, now your CD4 peripheral blood lymphocytes go down and down and down and down, and eventually reach a threshold in which the number of CD4 positive T cells cannot maintain a proper immune function, and now you start having the symptomatic phase, and then you have opportunistic infections coming in, and eventually you have death. Okay? This is a classical example, once again, of thrush, of oral candidiasis in an AIDS patient. Once again, most of these things are either caused by opportunistic infections or by certain tumors. For example, this is a Kaposi sarcoma and candidiasis in an AIDS patient. Okay, this is happened to be an oral lesion, but here is a skin, Kaposi sarcoma. Okay, so these are usually the problems that come at the end where your immune system cannot keep things in check anymore. Okay, so people say, well, wait a minute. Why can't you respond to this virus? You do respond, and as a matter of fact, the diagnostic approach to see whether you are HIV positive involves checking for antibodies to viral components. Okay, you take your serum and you check for antibodies initially using an ELISA, it's an immunoassay, and then a Western blot to make sure that your antibodies are against specific viral components. Okay, so you do mount an immune response to HIV. Unfortunately, it's not effective. The reason is for various different reasons. Okay, for instance, the virus rapidly mutates. Okay, this is also a problem when you're dealing with vaccines. Okay, this is why you also don't have a vaccine against the common cold, because it's a virus that mutates very rapidly. Okay? And also because it hides away in your genome. So there must be work to vaccines, although there's pessimism once again, because the purpose of a vaccine is to create an antibody response to the bug. But you do make an antibody response to the bug, and obviously it's not that effective. Okay? And of course, drugs to try to inhibit various different components. Okay, the virus has various different components that it uses to either A, penetrate the cells, so you try to block that particular interaction between the virus and the cell, or it has an integrase where you have the virus trying to insert the DNA, his genetic material into the genome, or you have something that inhibits reverse transcriptase, which allows the virus to convert RNA into DNA before it inserts to the genome. There's a whole bunch of different things. You know, I could give 3-hour lectures on the therapies, okay, but right now that's what it is. All right. I like this picture. Any questions? If not, we're done.
Would you ever explain again what peripheral tolerance versus central